Thank you guys for having me here today. Scott Herman, CEO, founder, New Day Healthcare. I've been extremely fortunate in my career to manage some pretty large companies in the space and built some companies from little bit to $1 billion. My good friend Adam Nilsson, he helped me build $1 billion company right here in the United States. It still exists today. In 2019, I left that piece after 5 cycles in private equity to start cycle number 6. But I said, we can't keep doing it the way we're doing it, because in 2019, the valuations became so exorbitant. The debt became so great. The only way to build bankable models was to create a model that took away from patient care directly. I'm a nurse by trade, and it's just against my nature. And you know, 2 things don't change. That's nature and nurture. Well, we say 2 things don't change. That's Mother Nature and human nature. But I refused to do that. And so I said, let's burn the ships. What does that mean? Let's think about everything different. This Medicare Advantage freight train's coming at us in the home health sector, and we got to think about how we're going to do this different. If we do it the same, it's going to be the same cycle. Because we knew something was going to happen, right? Something was going to happen, and it was going to be that interest rates were going to go, the economy was going to shift. What we didn't know is that there was going to be a global pandemic. 2020, I sat down and started this company, and I brought in some key executives, and I said, look, guys, I've been thinking about this for a while, and I'm going to do this. I wrote a purpose statement, and that purpose statement started out to say, here's where we want to end. Here's what we want to do. That purpose statement started out 7 pages long. Well, it'd be pretty boring and pretty hard to execute on that, and I brought it down to 4, and I brought it down to 3, and I brought it down to 1, and I brought it down to 8 principles. 8 principles upon which we could build a company that could change the way we think about healthcare. And then I went out to some team members and said, I got to talk to you guys. Come to my kitchen table. Let's look at this purpose statement. Do you agree with this? And they said, yeah, and it was principles like, let's do what's right. Let's take care of patients first. Let's not take short-sighted partners on. Let's only accept reasonable returns so it doesn't beat us up. And then I gave the worst sales pitch in the history of sales pitches to these people. I said, here's what we're going to do. If you want to do this, here's what I need you to do. I don't have enough money to do this on my own. I don't have a partner. I need you to volunteer and keep track of your time. You guys want to start? You know what? They said yes. One of those was my wife, Kim, who some of you have met. She was with me, and I said, honey, for us to do this, we're going to push all our chips in. We push all of them in, push a big chunk of them in. And those other people, I said, not only can you volunteer, track your time, I hope to get you paid, but I'm going to need you to write a check when I find a partner. Now, fortunately, I've been in the business long enough, had a whole bunch of private equity sponsors saying, hey, let's do it again, man, let's do it again. And I said, I know that 5-year cycle. I know that fund life doesn't work for what we're trying to accomplish. We never got in this to build the biggest. We got in this to take care of patients side by side and move them forward. So I found a partner. I found a great partner. Caltroco is my investment partner, and they're the private family fund of a gentleman named Steve Coltis. Steve is one of the co-founders of CVC Capital. It's the largest private equity fund in Europe. Steve's from Philadelphia, but he lives in Switzerland. And Steve asked me this question. So we're in the middle of COVID, right? The only one that could actually probably go anywhere was him on a private jet. I didn't have one of those. So we were on a Zoom call, and Steve said, how are you going to change healthcare in America? I said, I don't know that I can change the whole system, Steve. But if we take and pull these pieces together, and we show what we can do with data, and we treat patients like people, not like payers, and we treat them over years in a longitudinal way, we can make a difference. Because today, we're treating them by payer, we're treating them by incident. That's an episode, that's a patient day, that's an hour we deliver. We're not taking care of them holistically. Steve looked at me and said, let's go. Send your check in and I'll send mine in. So I went back to those other people. I said, I don't have you paid yet, but I am going to need your check. And they came aboard. So I put together a team. That team put together a team. Many of these faces you'll recognize. Some of them you know. Many of you know them. But this team has done deals from $1 million to $1.2 billion. Collectively, over 180 years of experience, seasoned M&As. We've done 150 deals with these guys. This team said, we'll write a check, we'll volunteer, and we'll be there. Now, just in fairness, I got them paid, right? Got them all paid. Our thesis was this: we're going to build a $110 million company, use that company as a platform company that we can inject into a large strategic. And when my sponsor said, why is that the point? I said, because we got to tie the technology together. We've got to bring the patient bases, get all the data in one place, and prove we have outcomes. Why is that the point? And I said, because you build $1 billion enterprise and it's just out of your control. You can't innovate as quickly in that enterprise. So we took this $110 million company and we said, let's go. Let's do it over a few years. We'll inject it into a strategic because I had lived under this wrongful impression for 20 years of my home health career. I believed if I accumulated enough mass, I could sit with CMS and they could hear us because our value proposition was so great. I know some of you that have been doing that for 3 decades are probably laughing about that notion right now. But we got to $1 billion and we sat with those officials. And you know what they told me in a roundabout way? You're a rounding error. Pre-COVID, right? We got a little tension after COVID. They said, you're basically a rounding error. So I realized for 2 decades trying to build mass, we weren't going to get there. So what we had to do was create innovation. So we started out with this little $110 million platform we hope to inject. And today it is. Today this is our little company, New Day Healthcare. We're a full care continuum, home health hospice, PCS, PDN, private pay, CDM. That's our palliative care program. Average daily census is about 11,000. We'll touch about 120,000 lives this year with 7,000 team members and 33 locations in 4 states. Our little $110 million company will do $300 million this year. We deployed the bulk of our capital in the fourth quarter of 21, so we're about 2.5 years really into this. This is state of the market. You guys know this. The current market situation, someone turns 65 years old every 8 seconds, 10,000 a day, you know the drill. Look how it's advanced. This is Kaiser Foundation stuff. From 19% in 2007 to 51% today. We know MA's coming at us. It's been a big freight train. I was having breakfast with someone this morning and I said, it's funny that we've been talking about this for 10 years and now all of a sudden we're surprised that Medicare Advantage is here. How do you tackle it? We don't think there's any signs of this slowing down. Maybe it decelerates a little bit with some Medicare changes, but we think that it grows faster because there's an entire generation turning 65 that are used to 30 years of managed care. They're used to having restrictions on how they get services. They're used to having benefit restrictions. So we think this accelerates even faster. Burn the ships. We said we're going to rethink everything. If we can't rethink everything, we're not going to do it. Unfortunately, we had a sponsor that backed us. A sponsor who said, let's be patient, let's be innovative. You know, we think that home care delivery's got to change. It's got to adapt significantly. You got to take care of patients, not just verticals. You got to take care of the person across time, not just a payer, not just an incident, not just an episode. We think playing the rate game only, we think, is a losing proposition. We think that over time it's going to burn you. We think the industry is currently having some trouble, and that that bricks and mortar might be a dying episode. So I talked to you about taking care of patients. I talked to you about taking care of them in a longitudinal way. I talked to you about treating the person, not the payer, not the incident. But then we've got this Medicare Advantage problem, so we had to attack it. So we bought a company in Texas, and that company, there's some woohoos from Texas. That was a remote company for 20 years. It was a therapy staffing company. And their biggest clients were home health companies. And they said, hey, how come if we have all these home health cases that people aren't taking in Medicare Advantage, why don't we take those? So they began to do that, and they built this remote model. And when we looked at it, we said, we can take that, and I think we can innovate it. It had some technology with it that didn't really work out. We had to replace it. But what we've built in Texas is a remote model that covers the entire state from that blue star in Addison, Texas. We recruit, onboard, train, schedule, serve all of our patients from that one location. Average daily census is about 1,200 patients on ADC, about 800 employees. What that gave us was a very low-cost model that allowed us to go into the MA world, and that's a 73% non-episodic business. It's not a 73% Medicare Advantage business. It's a 73% Medicare Advantage fee-for-service business that has about 27% in episodic care. Hey, we tried to tip it. We tried to say, how far can you go and not lose your shirt, not produce relatively stable gross margins in the mid-30s and get about 10% to the bottom line? How far can you go? We can't go much farther than that. We're right about there. This is it. But as you guys face, everything you guys face is the same things we face. We got a labor problem. We're trying to solve for labor. We turn away about 1,200 qualified referrals a month in our business. And most of those are scraped off of portals. But we tried a couple of things on this model, and I'll tell you about a couple of failures. The first one was we bought a small provider in East Texas, and we thought we can cover the entire state. The other providers in East Texas are the red stars on this map. So we cover the entire state. We've got great managed care contracts. We got a model we think works. It produces decent gross margins. We can get out there and put some money on the bottom line. Let's buy these small companies that are episodic based with a few hundred patients, and let's wrap them into this. Let's integrate them into this big state model. Problem with that was, when we did that, we completely diluted the episodic mix in that business, and we crashed it and it burned. Still there, but we're having to rebuild it. So the next couple we bought, we said, let's keep the episodic business in place because that's what everybody was focused on. That's why we bought this company. And let's lay this over the top of it as a wrapper, and it becomes a relief mechanism for that episodic business. So we've created a model that now we can buy those episodic businesses, we can move them along, and we've got a statewide relief valve for them to pick up those Medicare Advantage contracts that they're struggling with. Hey, Scott, you said a lot about let's take care of patients. Let's take care of the patient, not the payer. Let's not move ourselves down this way that we're isolating them. We're not taking care of them holistically, and we're not doing it in a longitudinal way. But you just talked to me about a Medicare Advantage vertical in one business line that seems pretty siloed. I heard siloed this morning from our panel. Seems pretty siloed. But this next slide will tell you why we're trying to resolve that. Our Carelytics system is some software, it's people process and technology, it's data warehouses, it's software, it's things that we created to do just this. Bring data feeds from any source. Those sources can end up in our warehouses. We run them through this wheel of our services in the gray there into our Carelytics platform. We're able to take the data there, work with it however we want it, change it however we want it. We can import from anybody, not just home care, anybody. In fact, we have a large national public company that sat down and talked to us, and they take care of patients in a capitated agreement under heart failure that kind of crash into their major service line. They said, how do we keep them people out of that crash phase? Put your data in here, we'll give you all the stimulants, we'll show you how to do it. And they said, we want to buy the software. I said, software's not for sale. I spent 15 years trying to figure it out. But we can take them, we can push the data out in any format we want. Seems logical, right? This seems very logical. Why don't we just get all the data, all our service lines, put it all together, and start thinking about how we work with patients? That seems very, very simple, but everybody in this room has been trying to do it for a decade, just like we have. I'll tell you why it's so hard. This is one of our 3 data stacks. Now, you're going to be really psyched because I'm going to walk you through this in excruciating detail. Man, I ain't even capable of walking you through this in excruciating detail. When I was in Catholic Health, at Via Christi Health Systems in Wichita, one of the things they do is they help you as an executive identify your charism. And your charism is your God-given ability. How do you take your God-given ability and expand on it? And my charism was not to explain these diagrams, but it was to get people around me who understood the things I didn't and help them succeed by getting out of the way, show them a vision. This is one of 3. This is the most complex, but this is all the data that we take in to just try to figure out where the heck everybody is just to build a data warehouse before we ever do any analytics. It's complex. It requires external data warehouses. It requires AI. I've got 3 programmers working on it full time. We're running AI now to run through our insurance authorizations, run through what our scheduling looks like, tying that to our staffing, seeing what staff has put in, and now we're just trying to say, can we actually get it to the schedule? You know, we're 95% there, but that 5% is tough. Because guess what we have to do? We have to pick up the phone. We need to talk to that clinician, and we need to say, how's your day going? What's happening with your day? How's your schedule look? Anybody fall off? Can we go ahead and insert this and add it? And then we can start moving that volume. But this is why it's so darn hard. But when you pull it together, it looks like this. This is a single patient journey. This is a patient who entered different programs, had an incident. That incident allows us, we run our algorithms against the data. We track what they're doing. We look at what's happening in a patient's life journey, and we look at key incidents. Those key incidents help us identify that a patient's had a problem, and through pattern analysis, they're about to have another one. This helps you do things like drop 30-day all-cause rehospitalization rates from 28% down to 7.8. Helps you do things like take fall prevention from 25% down to 7%. It helps you do things like extend the time that a continuum-based patient is in their home by 806 days. 2 years. What do you do with that? Well, our driver is we're keeping that patient at home. They're in our circle of care. We're moving that patient along. But when I go to MCOs, I tell them, you just got your PMPM for 2 more years. And we're helping drive it. And they like that. They don't like it enough to pay us really well. But our patient analytics model in the single patient journey allows us to dive in, look at the data, understand what's going to happen, take on large-scale patients. We're 35% deployed over our current footprint. The footprint that I showed you, 35%. Here's Carelytics by the numbers. Patient daily census is around 11,000 for us. We have 80,000 patients in our patient database, so we're tracking 69,000 patients that aren't even on service. We're tracking them in the community. We're keeping track of them so that we know when something happens, they can come back. I know you're looking at the bottom. Oh, sorry about the outsourced referrals. I thought I changed it and we inserted the wrong deck, but this is cool. Outsourced referrals are $1,200. Our patient acquisition cost from this program is $135. How's it so low? I'll give you my father as an example. He's 87 years old. He didn't really have a lot of health issues, but he's got a little COPD, and if you ask him, he'll say, it's my fault I smoked for 62 years, and he loved every minute of it. But he said he started having some respiratory issues, and he's on Humana. I moved him over there, by the way. I know that's a sin in this room, but I moved him over to an MA plan because he could get dental care and eye care, and he didn't have a lot of meds, and he could pick up some of those social determinants. I moved him over, and we saw him a few times, and he went into our program, which was our CDS program, our chronic disease management program, chronic disease management CDM. And they saw him a few weeks in a row, and then they saw him a little less, and a little less, and then they call him in between, and we do about 110,000 outbound calls a year based on those data, the way we stack people. And my dad gets his contact, and guess what happens with my dad when he has a problem? Nurse comes and sees him. She comes back out. We reopen another case because my dad is going to fall in this continuum, and he's going to need that full cycle of care. We do that through our Carelytics program. Burn the ships. This is what it means. It comes from a song by For King and Country. We pulled it because we said we have to rethink everything. We got to burn the ships, leave it behind, push in all the chips, and let's go. And I was very kind to receive an album signed by the band For King and Country last evening. And one of the things that it really brought home to me is we've picked the right mission. We've picked the right desire. We're meeting our purpose statement. And we're going to go, and we've had this $110 million platform ideology that's now almost 3 times larger than that. And what's the value of it, and what will it drive into a large strategic? I encourage us all here today, burn the ships. Think about it different. Go at it a new way, because if we don't, we're just going to keep in the same old cycle. You heard our panel talk about how we were just complaining. We got to stop it. If you're in this room today, you're here because you chose to care. That's a big statement. You may be a vendor helping with automation. You may be a provider. You may be someone that's out there hustling it every day to get clinicians to the bedside. But if you're in this room, you chose to care. I'm going to tell you a quick story. It's about David. David was a diabetic patient I had. I'm a nurse by trade. I was a per visit nurse at the time. David was a diabetic patient that I had. David had foot ulcerations. And those of you that don't know what happens with diabetics with foot ulcerations is eventually they start carving it up. And they start taking pieces off, and a lot of those patients end up with below-the-knee amputations. David was one of those patients that was headed down that path. His doctor said, if we don't turn this in 6 weeks, we're going to have to start cutting your feet off. We're going to work our way up to your knee. So I'm working with David, who's got some pretty significant foot wounds. And I said, David, what do you want? What's your goal? He said, I have an 8-year-old grandson who I practically raised, and I want to watch him pitch. He's moving up to kid pitch, moving from T-ball and coach pitch, and he's going to pitch this year. And I want to stand on the fence and hold the fence, and I want to watch him. And I want to do it on these shoes. He called his feet shoes. Man, we worked and worked and worked, and I'd seen BID, so twice a day and many times a week and then daily, and we spent thousands of dollars on his feet. 6 weeks, he goes back to his doctor, and she says, you know what? I don't think we're going to do that amputation. I think we're going to hang on. The last time I saw David was on a Saturday morning. I told my family that I'll be back. I got to spend about an hour and a half taking care of some business. David went up in his went up in his walker, let go of his walker, and held onto the fence. I watched his grandson throw one pitch. One pitch. I got in the car. I drove away. I didn't see David again. David's shoes is why we're here. If you care, and you're here and you do care, thank you for choosing to care. Because the lives you touch, people like David, are changed forever. If we don't figure this out, it's not going to get figured out for us. So burn the ships. Let's figure it out. I'm going to go to the lyrics real quick. Burn the ships, cut the ties, send a flare into the night. Say a prayer. Turn the tide. Dry your eyes and say goodbye. Step into a new day. Guys, at our organization, we say this. We say onward with God's speed and go burn the ships. Thank you, guys. Let's go burn them.
Thank you very much, Scott. Thank you very much.